A lot of people ask, what about ultrasound in pediatrics? Well, what we have in pediatrics are quite a few advantages that make ultrasound even better than perhaps in adults. Number one, in children, their organs are closer to the surface. They're not as enveloped and concealed by bones. Number two is that children don't have as much adiposity. They're not as fat as adults. So the penetration of the sound waves is increased. And number three is that children tend to be a little bit healthier, so their bones are not scarred, their tissues haven't been damaged, and so you get a little bit better of a pristine look at the essential organs. Number four, and very important in the media right now, is the fact that children have a much longer lifetime incidence of potential malignancy due to alternative forms of imaging, such as CAT scan, conventional radiography. So we think that we're protecting them, particularly over the course of their lifespan, when we opt for a non-radiating alternative such as ultrasound. People will ask, how does ultrasound enhance the family's experience in the pediatric emergency department? Well, at least three ways. Number one is that I think it makes us better doctors. When we do ultrasound, we are right there with the patient. We touch them, we can look at the image with the child. They're usually fascinated by it, and I think it really increases their enjoyment of the experience. Number two, I think it's incredibly important that it brings us back to the anatomy and physiology that we learned in medical school. So often in modern medicine, we don't touch the patient. We don't spend much time on the things that we learned and worked so hard on in previous educational experiences. And number three, the parents absolutely appreciate it. The parent satisfaction is increased markedly with ultrasound, and they feel like the physician is more competent and they're more likely to follow the physician's directives. We're here in our trauma room, and we're asked, what are the parts of pediatric emergency ultrasound? At least three. Number one is we use it for diagnostic purposes, and it's amazing the number of different diagnostic applications that are being developed. Literally, they're growing exponentially from every system imaginable. So we do an awful lot of that. The second thing is we use ultrasound for procedural assistance. As we all know, we don't want to do procedures blind if at all possible. So ultrasound allows us to identify the organ, watch the needle approach it, and absolutely has been shown to reduce error and repeat procedural attempts in a variety of different settings and in a variety of different procedures. Number three, and I think is most exciting, is resuscitative ultrasound. We use ultrasound now for a variety of different trauma and non-traumatic applications, and the exciting thing I think we're looking at now is the use of ultrasound for undifferentiated shock. In regard to shock, we find that ultrasound has assisted us in a meaningful way. When patients arrive in the emergency department in serious condition, a lot of brain fog will tend to take over. And so it's very important to have a conceptual model where you can be guided without having to think too much about what your next move is. And a variety of different models have been developed. What they all seem to have in common is focus on the heart, on the inferior vena cava as kind of the storage tank, and then the pipes or the circuit where the blood travels through between the heart, the tank, the IVC, and the rest of the body. So first we look at the heart and we see if it's contracting well, we see if there's normal symmetry of the heart, we see if there's any morphologic abnormality, or we look at the heart and see if there is a particular site of strain. Right ventricular strain is of course common with pulmonary embolus. Second, we look at the inferior vena cava, which is our tank. It looks at volume, and we can have a well-functioning heart, a pump, but without a full IVC, without a full tank, it doesn't do us much good. And then third, we look at the circuit. We look at areas between the the heart and the rest of the body before the blood returns to the IVC, and we look for obstruction or extravasation. So we look for integrity of the circuit where blood or fluid may be lost. So talking about the pipes or the circuit, there are a variety of different areas that we need to address when we look at this. The first, of course, is the pleura. We look at the pleura and we see if there's a normal lung slide. If we don't have a normal lung slide in the context of trauma or in certain illnesses such as cystic fibrosis, we may see a pneumothorax, and that is something that we need to immediately address. Number two, we can look at the pleura and see if there is what's called a lung pulse sign. It's a little bit different than a lung sliding sign. The lung pulse sign is an indicator of hypoventilation, usually as a result of hyperinflation. And this can be an indicator of obstructed blood flow back to the heart and can cause serious cardiorespiratory compromise. Number three, we like to look at the lung parenchyma. The lung parenchyma is a little bit deep to the pleura, and what it allows us to do is look for third spacing or escape of fluid from the vascular compartment into the interstitial space. And this is another thing that's very important in patients that have shock or have respiratory distress. Moving from the lungs, we'll then go to the upper quadrants of the abdomen, and we'll look through the actual liver and spleen to see the lower aspects of the lung. So when we look through the right upper quadrant organs, through the liver, what we'll look for is signs of fluid that has displaced air. Normally, immediately above the diaphragm, opposite of the liver or spleen, we'll see air fluid structures, which are, of course, don't reflect ultrasound waves. But when there's abnormal fluid there, we will see a reflection of a fluid density, which is normally black. On the left side, we'll look through the spleen, up above the diaphragm, and we can see the same thing. We can see fluid, a pleural effusion, a hemorrhagic pleural effusion due to trauma, and a variety of different pathologies. Again, the point being that we see fluid only in the presence of pathology. Now, as we go into the pipes, what I want to emphasize is the fact that we are absolutely in need of doing this simply. We have to make it simple because, again, we have a sick child. We can't interrupt the normal resuscitative efforts initiated by the staff. So we have to kind of fit ultrasound into everything else that we do in a very time-compressed fashion. So the pipes, how do we start? First, we're going to look at the pleura. So we'll put the probe right over the lungs in a sagittal direction, and we're looking for lung sliding. If the lungs are not sliding, if the pleura are not sliding, meaning the visceral and parietal pleura are in apposition and going back and forth, then we are worried about a pneumothorax. A permutation of lung sliding is called lung pulsation. In lung pulse signs, what we'll see is the lung is in apposition, but the movement isn't smooth, it's jerky. And this is an indicator of hypoventilation, usually due to hyperventilation. And so that's what we look for as far as lung sliding and lung pulse. Somewhat subtle, but very useful. Then we move to the lung parenchyma. The lung parenchyma is an extremely important area that's really being developed. What we think is that the lung parenchyma may be a kind of a surrogate marker and a representation of intravascular integrity throughout the rest of the body. So when my lungs become filled with fluid, that may be similar to what happens elsewhere in the body when capillaries leak. It can also serve to guide me as far as resuscitation. If I've given too much fluid, I will see fluid in the lung by virtue of looking at the lung parenchyma, something called B lines in the lung. Now, moving from the parenchyma or the lung itself down to the upper quadrants of the abdomen, we'll use the liver and spleen as what we call an acoustic window. An acoustic window allows us to see through things where we wouldn't ordinarily be able to see. And we look through the liver and spleen in order to see the lower areas of the chest. So what we're going to do is we're going to look above the diaphragm and we're going to see if air is displaced by fluid. Again, fluid in the chest, in the lungs, is not normal. So if we see real images, fluid transmitting and reflecting the sound waves back to the cursor, we have a problem. If we see nothing, or if we see pure artifact, that's what we would expect to see with air-filled lungs. So it's very important to look for things in the lower chest, such as pleural effusion or signs of trauma, traumatic pleural effusion. Now, moving further down the abdomen, in regards to shock, what we want to look for is fluid in and around the abdominal organs. This is a big part of the circuit, and this gets us back into our traditional FAST exam, focused abdominal sonography in trauma. And what we're doing here is we're looking for free fluid around a variety of organs in dependent areas of the peritoneum. One of those areas is the Morrison's pouch, which is well known as a recess between the right kidney and the liver. The left spleen area is also recessed, dependent, and can accumulate fluid, which is easily seen in contrast with the organs. And then finally, we look at the pelvis for fluid, again, within the intraperitoneal cavity. Again, a very dependent area where fluid in a supine trauma patient will collect. Now, that's not it. Still, we have more. We can look at the femur in children. Femur fractures can cause a considerable amount of blood loss and cause cardiorespiratory compromise. And then finally, in infants, the head can accumulate, because of the open fontanelles, a significant amount of blood loss and can contribute to shock. So we always try for the little ones, when we don't have a reason for their shock, we don't know for sure, we'll actually look through the open fontanelle into their brain and see if there's bleeding in their brain. One of the best parts of pediatric ultrasound is the fact that they're smaller and they have less cutaneous body fat. Therefore, there's less distance between the surface and the vital organs that you're attempting to insonate. As such, we're able to use increased frequencies. We compromise depth, but again, there's not that much depth. So with the increased frequencies, we don't have to worry about lack of depth, and we're able to get great images of the vital organs in children. So we tend to use, like I said, the higher frequencies. This particular probe is a C93, which is a very high frequency probe and has provided us wonderful images of a variety of different body parts. For even more superficial images, we'll use a higher frequency probe. That is usually something in the realm of 10 megahertz. So we have another probe for very superficial structures, such as blood vessels, skin abscesses, cellulitis, and things of that nature. Now, on occasion, we'll have to look very deep, or in children that are much bigger. So we'll have a probe that has a lower frequency, but will provide us greater depth. And we'll use that for intra-abdominal examinations in the bigger kids, as I said, or some cardiac evaluations. Another great thing about ultrasound for children is it allows us to use a guide for our procedures. We never want to stick people blindly, and of course parents are very unhappy when their children have to endure a number of different needle sticks in an attempt to get an IV started or another procedure. So we use ultrasound to guide a variety of different things that we do. One thing that we do a lot here in our department is ultrasound guided nerve blocks. We found that after, say, a femur fracture, when a child is very uncomfortable and may not go to the operating room for reduction of that femur fracture for a number of hours, that a femoral nerve block is probably the single most kind thing that we can do for them. It can pretty much alleviate their pain for 6 to 8 hours and turn a horrible experience and a night full of narcotics and calls to the nurses and calls to the physicians to a very peaceful time where they can get some sleep before the procedure. On the screen here, we've showed a nerve. That's the median nerve, actually, and nerves tend to look kind of speckly. They have a honeycomb appearance, and you can see how if I can see the nerve, I can guide my needle into the image and deposit anesthetic immediately around the nerve, thereby anesthetizing the nerve from that point downstream. And we found this to be useful not only for the femoral nerve, but for a variety of other nerves in the body. And this allows us to not actually directly contact an injured and painful area until the procedure is about to begin, therefore making it much less fearful for the child. When people think of emergency ultrasound, they normally think of diagnostic applications. And we certainly do a considerable number of those diagnostic ultrasounds in our department. But it's very important that we address and be mindful of our relationship with our colleagues in radiology. They are very good at ultrasound, and they do a variety of very wonderful diagnostic applications. And we want them to stay good at what they do because they're the ultimate experts and they're our backup for studies that we may not do as often as do they. So the way we've worked it out, and I think the way it works best, is we have our own applications that we do, including abscesses and ocular applications. And then we also do some of our studies so that we can decide which is the best consultative ultrasound test to order. So we'll do an ultrasound as a preliminary for our radiologists and then ask them, could you look at this? Could you look at that? I've seen this on my ultrasound. Can we get this particular study so that you can really focus in? And we found that to be a very nice way to collaborate. So one of our most popular, most utilized diagnostic applications for ultrasound in our pediatric emergency department deals with the differentiation of abscess versus cellulitis. There was a study done in a very significant children's hospital quite a few years ago by one of my colleagues. And what they did is they looked at the ability of seasoned physicians to differentiate abscess versus cellulitis. Now, mindful that if it's an abscess, it needs to be drained. Antibiotics won't help. If it's a cellulitis, antibiotics will help. So the differentiation is very important. You don't want a child to receive antibiotics and not an incision of their abscess because they won't get better. On the other hand, if it's cellulitis and would respond to antibiotics and you provide an incision, you've given them an unnecessary scar and subjected them to the discomfort of the procedure as well as the risks of anesthesia. So what we do, and it's a very simple application, is we use the ultrasound probe, we put it directly over the area of redness, and we're able to see a pocket of abscess. If we see that, we know we need to do an incision and drainage procedure. If we see nothing but cellulitis, which is also a characteristic appearance, something that we call cobblestoning, we know that they will respond to antibiotics and we can avoid the incision and drainage procedure, thereby saving them the discomfort and the future scar. The old way was that we would kind of go blind and so let's take a child with a limp, for instance, a 2 or 3 year old child with a new onset of limp, looks reasonably well, had a viral illness 2 weeks ago. The pretest probability of this being a post-viral transient synovitis is very high. But in the past, what we used to do is a CBC, other lab tests. We would x-ray from the hips all the way down to the bottom of the affected leg to see if there was another possible cause for this limp. The child would spend a tremendous amount of time in the emergency department, undergo the discomfort of the IV, and at the end we might not still have an answer because some of these tests are non-specific and there's a tremendous amount of overlap between abnormal and normal. Now, the new way. We take our ultrasound, we look at everything I just said, but we look at it directly. Then we look at the hip, and if we see that there is a tremendous amount of fluid in one hip capsule versus the other hip capsule, the non-affected leg, then we can say, wow, this looks like this is a transient synovitis, just like I thought. Then we may give a non-steroidal anti-inflammatory. They start to work on their leg a little bit more, they walk, they're still looking well, and we feel comfortable going back to the way it used to be done. So the new way is actually the way it used to be done, where we used clinical judgment and didn't do testing that often led us to doing things that we didn't want to do. One of the things that we found about emergency ultrasound in children is that we are able to serve as kind of an extension of ultrasound and take it out to the other disciplines within the medical field. For instance, we talk about the field mentality. We have used ultrasound on the playing field and the mission field. The sports medicine use of ultrasound is increasing with the advent of handheld devices, and it's very popular among sports medicine doctors. And in regard to the mission field, we've taken ultrasound with us on a variety of international trips where there is no other imaging alternative. And we've used ultrasound in that area as well when there's nothing else for these children. Finally, we've become kind of a leader in ultrasound within the hospital or the pediatric community, where other specialists have come to us for instruction in point-of-care ultrasound. And so we've found that this is an exciting area where we're starting to branch out and broaden our scope.